orthopedic, trauma, hip, anything.
Okay.
What would be the first thing you would do?
Introduction and consent.
Explain the whole procedure to patients, sir.
Okay, so I think, we will start with the basic principles of any examination. First and foremost, before you begin, you have to introduce yourself, right?
Yeah.
That would be the first courtesy to your patient. Without introducing yourself, I think you cannot proceed for any further examination. Always keep a smiley, cheerful face, because, a smile always wins many hearts. When you are examining with a female patient, always keep a female attendant, not the relative. We should have our own female attendant to accompany us while we are examining. Explain the patient everything before performing any examination whatsoever. Even when you are trying to inspect, always try to explain the patient what you are trying to do and how you are going to do. Always make sure that patient's privacy is maintained. So, make a patient comfortable by pulling a curtain, sending unnecessary people out. So, you have to ask the patient, would it be okay for you to examine in presence of everybody, or you would want to send people around outside of the room? So that is a patient's prerogative, whether whom to allow and whom not to allow. So that is the fundamental thing before you start for examination. If you are working with your fellows, associates or student, it is very much polite to introduce whoever is accompanying you in examination. So if you are examining a patient along with your students, always make introduction of the student to the patient and seek permission to keep them along with you before you proceed for any examination. Always look into patient's eye, because it conveys the confidence and comfort. Wandering eyes are a bad omen. Patient will not feel comfortable, may even feel threatened. So we'll start with the history. Foremost, and I'll just try to cover up very important points also. I've not gone in, each and every point, which might be probably Dr. Pachore or you people are more accustomed to and than me, what I am now. So we'll start with first age, sex and occupation. Age I will take in a while. Anybody can tell me the importance of sex in spine examination? So I think Nimesh would be your next turn.
Don't know, sir. Age.
What is the importance of sex in spine?
Sir, in a congenital or a progressing deformities like kyphosis and scoliosis, the age till when the progression will be there. So according to treatment can be planned. So that
no, I think age. I think age we will take little later. First sex, importance of sex.
Sir, lumbar lordosis will be more in females.
Okay, that is one thing. Second,
spondylolysis is also more common in female.
Well, I think these are probably very nasty things. Your examiner can always start stretching you on so many things. So always reply. See, remember, when you are probably this entire lecture is for your examinations. So don't reply about which you don't know much. So if somebody asks me that, what is the importance of sex, I'll say that female is more prone for osteoporosis. Let examiner ask more about osteoporosis, because I might have read for my full question. I know osteoporosis ins and outs. But the moment you say congenital deformity, he will say, what will be the difference of deformity between male and female child? Right? That will be the next question. So always remember, why I'm saying this, that when you are replying to your examiner, you should be very much aware about what you are replying, because your entire viva will go on what you reply. So it's a tricky thing to probably, take your examiner on the line what you want him to ask. So if you say osteoporosis, then your viva may entirely get finished in osteoporosis, or 4 or 5 questions in osteoporosis, and the examiner will have first very good impression on you, right? So always reply what you thoroughly know. It's okay, you can say degenerative things are more common in female. So these are simpler to explain. Congenital deformity, spondylolysis. I would not want to reply that way. Okay, importance of occupation. So occupation in spine, generally those who are in heavy lifting or a manual labor work can have more muscular pain. A person who are more into vibratory, using of vibratory equipment, can have more degeneration of disc. So that is the importance of occupation. Now let us look at age. What are the common disorders in specific age? So in children, very much young, scoliosis, spondylolysis or a listhesis, infection are more common. Even some tumors like chordoma is more common in early ages. The adolescent group, Scheuermann's kyphosis, scoliosis or infection. Once you reach young adult, mechanical back pain becomes more commoner symptoms than anything else. So first, when your patient comes in a young adult group with back pain, first diagnosis you should come to your mind would be mechanical back pain, because that would be the commonest thing. Then would come a prolapsed intervertebral disc, spondylolisthesis, lysis, any fracture, ankylosing spondylitis starts around second, third decade of life, and infection. If you go for middle age, the mechanical back pain would be another very common part. Osteoarthritis starts at this middle age time, spinal stenosis, some metabolic disorders, spinal metastasis and infection. So metastasis starts, infection continues. Infection is something which is continuous. The old age, when myelopathy, osteoarthritis, osteoporosis, osteomalacia, metastasis, stenosis, disc. So all this majority of spine problem comes at old age. So spine per se starts from child and goes up to the patient dies, but more common symptoms starts from middle to late onset of your age. So what are the chief complaints? The first chief complaint we would want to discuss about is back pain. So we always ask your patient before, patient would say that location of back pain. Naturally, patient will come up their location where the back pain exactly is. We will take location slightly later. The importance of duration of back pain. We all know acute, chronic, and intermittent. So acute back pain would point a diagnosis for some recent event which has happened. It could be a disc herniation. It could be a muscle spasm. It could be annulus fissure or annular tear, or just a kind of a disc degenerative SI joints pain. Chronic back pain. Chronic back pain is more to do with sometimes non-specific also. So if somebody says that your patient is having a chronic back pain, the first thing would come to my mind that it could be a non-specific back pain, because commonest reason for chronic back pain is non-specific back pain. And intermittent back pain comes and goes, generally is non-specific back pain. So difference between mechanical and non-mechanical, I'm sure everybody would be knowing that what is mechanical back pain and what is non-mechanical back pain. So mechanical back pain is a back pain which aggravates with any physical activity like standing, walking, sitting for a long time, weightlifting. So any back pain which aggravates with some kind of activity is termed as mechanical back pain. And most mechanical back pain can have a structural cause in your spine. Non-mechanical back pain are persistent all throughout, whether you exert your body or not. The back pain is persisting, and the cause are, these are generally called non-mechanical back pain. And the major portion of non-mechanical back pain are non-specific back pain. However, there are some cases like infection or a recent acute onset of annular fissure, which will give pain even in a resting position as well. But prolonged non-mechanical back pain, first diagnosis would be a non-specific nature of back pain. Any positional aggravation like turning in bed, getting out of the bed, getting into the bed, if this gives pain or not, that is signifies that recent muscle spasm or injury over the disc or a spinal instability, which generally postural. When your patient tries to stand from a sitting position, it has to take support, or it's very difficult for the patient to get up from a chair, then most of the time that is suggestive of some kind of instability which is there in the spine. So postural aggravation generally indicates that whether your patient is the spine is stable or not. The next is night pain. The most significant thing about night pain or evening rise pain is it relates with infection, it relates with tumor also. So night pain is another very significant thing. And the third most important thing about night pain at the end of the day is sometimes muscle fatigue, because your patient's muscles are not strong. Patient is continuously has probably doing some mechanical activity that led to muscle fatigue. So muscle fatigue generally gives night or evening time of pain. A very late night pain at the time of bed can be a symptom for your tumorous etiology. The sensory symptoms, next patient would say to us, mainly patient comes to us with numbness. So where is the numbness? What kind of the numbness? That is most important. Whether the numbness is persistent or whether numbness is intermittent. What do we mean by persistent and intermittent? The numbness which doesn't go at all. So if a patient with diabetic polyneuropathy, generally the numbness doesn't go at all. When numbness is all the time present in kind of a Stocking and globe kind of a distribution. Intermittent numbness mainly is seen in lumbar claudication. Patient walks after some time, after walking for some time, patient starts having heaviness in the leg, numbness in the leg. So intermittent numbness generally is associated with mechanical kind of a symptom. In intermittent numbness, which comes and goes at its own will, generally is a malingering or a psychological. thing. The burning or hyperalgesia is generally found in peripheral neuropathy, diabetic neuropathy, or sometimes in a ganglion or sympathetic injury to your lumbar sympathetic plexus. If you have a disc herniation at alpha S1 foramen, extraforaminal part, your patient may only come even with hyperalgesia or a burning pain in a dermatomal distribution. So radiation, next would be radiation or a referred pain. Anybody can give me a difference between radiation and referred pain?
Yes, sir. A radiation pain is the pain is felt from origin site at origin site also, and it is radiating to other site also. The referred pain is the pain is not present at original site and it is present at some other site.
Okay, fine. So if your patient has an alpha S1 disc left side and patient comes with a calf pain, would you consider it a radiating pain or a referred pain?
It's a referred pain. If it's not present in lower back and it's present in only calves, then it's a referred pain, sir.
So here is the distinction. You know, if a calf pain is considered a radiating pain, if it is a proven disc herniation.
Okay.
Even though, because you know, it's a totally absolutely a dermatomal disc. So the radiation pain and referred pain, okay, definition is fine, but basic fundamental difference is radicular pain will have a dermatomal pattern. Referred pain is mainly a somites. So I mean, if the pain organs arising from same somite will have a referred pattern of pain. So if your patient is having a dermatomal distribution, you have to call it as a radiating pain, not as the referred pain, right? So this is the basic fundamental difference. I won't be remembering the definition what you said because I studied 20 years back, so I don't remember exact definition. But this is what my fundamental difference is, that if it is a radiating pain, it has to be a dermatomal pattern of pain, and if it is a radiating referred pain, then it is an organic pain from same somites, right? So generally, you know, that is what we call it. So this is one of the picture which shows that these are the different varieties of a referred pain, and along with the organ which will lead to a kind of a referral pattern. Radicular pain, we all know that it is in the distribution. So I mean, if you want to talk about in the sense of back pain, the basic difference would be that if it is a referred pain, generally it is localized to back. Generally it will refer to or above thigh level. Any pain which goes below the knee is not considered a referred pain, but it will be a radicular pain. It will not be a dermatomal distribution of pain. Or you can say that, you know, we can, when we talk about cervical spine later on, you know, when cervical spinal pain is more common, and myotomal pain is considered a referred pain, not the radicular pain, right? So always remember that in spine, lower lumbar spine, whenever there is a dermatomal distribution of pain, it is called a radiating pain. Non-dermatomal above knee pains are called referred pain. Okay, there is a specific difference to that, which I'll just take in a while. So location of pain is very important to identify whether it is a referred pain or it is a radicular pain. Again, duration of pain is very important. Acute duration indicates acute injury. Chronic duration indicates longer problem. Intermittent or continuous means, you know, mechanical, non-mechanical pain, same manner what we discuss about back pain. Aggravating or relieving factor. So generally radiating pain is aggravated by walking, standing, prolonged sitting, cuff reflexes. So all this leads to aggravation of pain. Buttock pain. So what is the peculiarity of buttock pain and a greater trochanter pain? Whether we consider buttock pain as a radiating pain or a referred pain. Isolated one-sided buttock pain. So buttock pain, yeah, go ahead.
It will be a referred pain, sir.
So, okay, so buttock pain, isolated buttock pain is now considered a radiating pain, because if your patient is having L5 dermatomal, L5 root injury, your patient can only present with buttock pain.
Okay.
Only buttock pain. So buttock pain can be referred pain, buttock pain can be radiating pain. Similarly, if your patient has a greater trochanter pain, would you term it as a spine pain or would you term it as a trochanteric bursitis? Isolated trochanter pain.
Yeah, so
Greater
more likely it would be a trochanteric bursitis. Yes, sir.
So how do you differentiate that?
Tension signs should be present, sir, if any spine pathology is.
Not necessarily, because here patient is only having, probably I would say, a radiating dermatomal pain at L5, because if you see L5 root or S1 root, they overlap, and the lateral aspect of thigh is for L5 root,
Yes.
right?
Yes.
So how do you differentiate? So trochanteric bursitis, we generally have a TFL stretch positive,
Yes.
right? That is one thing.
Yes.
Second thing, it will be a tender spot there.
Yes.
Okay, so these two things would be there in trochanteric bursitis, but still the pathognomic would be patient will have both this sign positive, and still patient will have a L5S1 disc herniation, and patient can present only with greater trochanter pain. We have seen n number of patients coming with greater trochanter pain, nothing there. Patient has been given injection multiple times for trochanteritis, and patients turn out to be having L5S1 disc herniation, right? So always remember that trochanteric pain can also be a radiating pain coming out of lower lumbar segment. The next thing would be claudication. So difference between ischemic and non-ischemic claudication, I'm sure everybody will know, but I'll just touch upon that in a while. So generally claudication from spine is aggravated by walking and standing. So we have to ask patient that, what will be the walking distance and what is the standing time. Now, what is the importance of that? Why we want to ask our patient that standing time and walking time?
Yes, sir. In a neurological claudication, whenever patient bends, flexion attitude is there, the pain relieved instantly.
No. What I'm asking is why it is important to note down walking distance and standing the time. With neurogenic claudication. Now, forget about vascular. We will take vascular in a while. But if your patient, when you are taking a history, you are writing down, the most important part is walking distance and standing time.
Sir, its walking distance is gradually decreasing and standing time is gradually increasing or not. We want to document that. Severity of claudication.
That is one very valid point, but that is only you can get to know on subsequent visits.
Yes. Yes.
So a patient comes to me today and patient says that, my walking time to walking distance is 100 meter and my standing time is 5 minutes. So what does it suggest? So it suggests that patient is having significant disability, right? 500 meter walking distance or 5 minutes standing time is not enough to pursue your activities of daily living. Patient will not be able to brush the teeth. Patient will not be able to shave. Patient will not be able to cook. Patient will not be able to go out. So, spine surgeries are mainly disability surgeries. So, entire exercise of spine examination is always to quantify disability. So, how do you quantify disability? One of the most important thing is to identify walking distance and standing time. You agreed that if it is in a patient, you can ask patient that, whether you were able to walk more before 2 months or it is decreasing. So, that is a significance on how rapidly it is progressing. But to identify disability, mainly it is important is that walking distance and standing time would be the most important thing. Relieving factors, always, we need to identify, because, if it is claudication, it only comes when patient is mechanically loading the spine. If rest also gives pain, then we generally don't consider it as a claudicating pain, because by definition, what is the definition of claudication? Definition of claudication is lower limb pain, disability due to walking, standing, and relieved by rest, right? So if it is not relieved by rest, it is not a claudication, right? So relieving factor, we always have to ask that whether patient is getting relief from whatever symptoms they are having by resting down or not, or which position. As you said that, there will be a difference between vascular and IC and relieving factors also. The importance of intermittent and continuous claudication. Any idea?
No, sir.
If your patient says that, I 2 મહિનાથી મને પેન હતું, વચમાં મને સારું રહે છે 2-3 મહિના, પછી પાછું એનો પ્રોબ્લેમ આવે છે. So we term it as an intermittent claudication, that there are intervening periods of good symptomatic relief and patient again goes into bad thing. So the importance probably again is in a treatment part, that intermittent claudication generally comes at an stage of claudication spectrum. So it's an early symptoms of lumbar canal stenosis, and they are patient you can conserve. See, what happens is, the pathophysiology of lumbar canal stenosis is intraneural edema, right? The stenosis or tightness of the lumbar structure or nervous structure lead to impediment in vascular supply, and gradually it will lead to edema, and that edema would lead to disability. So if this edema comes intermittently in a very early stage. So whenever there is edematous stage, patient will have claudication, patient rests for some days, patient reduces its workload, and edema subsides, and patient is again symptom free. And for some days it will again build up edema, and then will start having claudication again. So this is an intermittent claudication. And the importance is, these are the patients which are more amenable for conservative treatment. If a patient who is having claudication 6, 7, 8, 9 months continuously, they are very less likely to get benefit from conservative treatment. These are the patients who are more towards a surgical candidate. Okay. So another thing is, if your patient comes with continuous claudication, you can offer that, there are no conservative treatment which might help you. Either you accept the disability or you have to think about surgery, right? I don't mean the disability. If patient is able to walk half an hour, I will not offer surgery, but very severe limitation of activity with continuous symptoms since 4, 5, 3 months, 6 months, then I think these are the patient more candidate for surgery, and they will not improve with non-operative care. Some patient in claudication comes with sense of imbalance. They try to walk for some distance and suddenly they need to take rest or support. They tend to fall because of this vascular compression in a dynamic. It's a dynamic event. When you try to walk, there is gradually subsidence of your disc, which will lead to more compression, and suddenly there will be a cutoff of nerve function, and your patient will feel sense of imbalance. They will have to take support. They will walk with small step to avoid imbalance. And sometimes patient walks with a stooped gait also. Many patients term this imbalance as giddiness. And if you prod this patient, you ask them more, it is not the kind of chakkar what we see in vertigo, but it is sense of imbalance. The patient feel that padi java se. So don't neglect this particular symptoms in your patient when it comes to chakkar aava mande. This is a very peculiar symptoms patient will say, chalu sab chakkar aava mande, besi javu pade. So it is not chakkar, it is imbalance which is bothering the patient and not allowing to walk your patient. So these are basic difference between vascular and neurogenic claudication. In vascular, the walking distance is always fixed. Neurogenic claudication, it is variable. It depends on edema, whether you have rested or not all throughout. Like you can walk more when you get up in the morning, but at the end of the day, you will not be able to walk more in neurogenic claudication. However, in vascular claudication, once the vascular flow is established by rest, again you can walk the same fixed distance of time. So this is very particular about vascular and neurogenic claudication. Another important thing is palliative factor. In vascular, standing will abolish the symptoms. In neurogenic, standing or walking will not abolish the symptoms. Yes, standing will decrease the symptoms as compared to walking. Some patient in lumbar canal stenosis will be able to walk because single leg stents, the position keeps on changing. They are not loading spine continuously, but they will be more symptomatic in standing. So symptoms in standing is another very peculiar sign of symptom of lumbar canal stenosis, right? Because patient will be more disabled in standing than walking. We see patients who are able to walk for 1 kilometer, 2 kilometers, sometimes post surgery also 5 kilometers, but they will find it difficult to stand more because they have more issues with their nerve. So standing disability is a classical symptom of neurogenic claudication. Walking is both the way provocative factor. Walking uphill in a vascular claudication will be more painful. Neurogenic claudication has nothing to do with your walking uphill. Why so? Anybody? Why so? Why in a vascular claudication walking uphill is more painful, and there is no pain? It is painless in neurogenic claudication.
Yes, sir. Because in vascular claudication, if uphill walking during that muscular exertion would be more, so vascular metabolites will be more aggravated, and vascular claudication occurs earlier. While for walking uphill, the automatic flexion, the posture is in flexion. That's why neurological claudication doesn't occur.
So the fundamental difference between vascular and neurogenic claudication is, in vascular claudication, it is the muscle metabolism which is getting hampered by lack of vascularity that leads to symptoms. Neurogenic claudication is the nervous structure metabolism which is getting hampered, and that is leading to symptoms, right? So I mean, if you keep this 2 point in mind, entire difference are very easy to remember, right? Pulse and everything is fine, skin texture is fine, weakness generally it's okay. So another thing is cycling. They may ask, bicycle test is same like walking uphill because muscle is used more, right? So if you remember that in a neurogenic claudication, it is always the nervous metabolism which is disturbed and that leads to symptoms, while in vascular claudication, it is always the muscle metabolism which is disturbed and that lead to the symptoms. So another important thing is shopping cart sign, which is a stooped posture of a patient relieves symptoms. So with the advanced lumbar canal stenosis, patient generally walks with stoop gait, and we have termed that as a shopping cart sign, that patient need to stoop forward or take support of a table. We see patients who comes in our OPD, if we ask them to stand for 5 minutes, they will tend to take a support of a table or a chair. So this is a sign we always have to remember while dealing with lumbar canal stenosis. So as I said, that the another thing, patient will come to us with complaint of stooped gait or a disturbance in posture. So stoop attitude and a posture is always different, because when patient's attitude is patient want to purposefully has been habituated to walk like that, and posture generally comes with the attitude and posture of stoop comes with aging also, that as you age more, you tend to fall forward. Our spine has a tendency to go into a kyphotic kind of a deformity as we grow older, and that may lead to a stoop posture gait. However, in adult deformity cases, when you have an advanced degeneration, the sagittal imbalance, I think that is beyond the scope of DNB level, but just remember that sagittal imbalance, which is the most important thing in spine nowadays, is leading to this stoop posture. If your spine loses balance in its dexterity, then patient will have a stoop posture. Patient can have a stoop posture if patient is having osteoporosis with multiple compression fracture. Gradually patient will start bending forward and patient can have a stoop posture. Now many a times we see a patient with Parkinsonism where each patient walks with kind of a stoop gait. So always remember, always keep this thing in mind, because Parkinson patient will come with a stoop gait. Parkinson patient will come with back pain because with continuous rigid muscle spasm. So always try to identify your patients with Parkinson posture, mask-like face, some tilts, some small baby step gait, tremors. So all this, the slowness of the inertia in initiating movements, all this thing always keep in mind before jumping on that. This stoop gait is isolated only because of spine. Another postural complaint, patient may come with a list. List is swaying of trunk on one side. It loses the center of your CSLV and sways on the other side, and what we call it is a list. So any idea that whether patient axillary or shoulder disc, what kind of a list will be? If your patient has an axillary, the difference between axillary and shoulder.
Yes, sir. In an axillary type of distribution, the patient will list towards the same side, while in shoulder type, the patient will list towards the opposite side.
How so? Why? Can you explain?
Yes, sir. Because the nerve root, it's dependent on the relationship of the disc bulging and nerve root. So, so in axillary type, by tilting towards the same side, the nerve root goes away from the extruded disc material. So that's why it's relieving the pain, and that's why the patient leads toward the same side to relieve the pain.
So always remember, this is your axilla. So if your disc is here, right, you're able to see me on the screen, right?
Yes, sir.
My photo, my video. So
yes,
if this is an axilla, you tilt over this side, your root goes away from the disc, right? So axillary discs always lead to, if you tilt on the same side, it releases pressure from the root. And if it is a shoulder disc, you are pulling the root away from the disc, and that's how you are relieving the pressure on the nerve. So that is why always axillary disc will have a same side list and shoulder disc will have opposite side of the disc. Loss of height can be a complaint from your patient. Generally comes from a kyphotic attitude of a patient coming out of multiple osteoporotic collapses of your disc. Patient may come with a gait complaint as well. So these are main gait pattern what can lead to a different kind of a gait pattern. I know that a patient will not say that we are having an antalgic gait, but just for completion of this, I have also tabulated them. That antalgic gait generally have a painful gait. Patient is not able to put weight on that particular limb. We need to identify the pathological site from where the pain is coming, whether it is spine, whether it is hip, whether it is knee, whether it is ankle, whether it is heel. Anything can be there and can lead to an antalgic gait. So antalgic gait is only indicates one thing, that patient is not able to take load on that particular limb. The reason can be anything. Trendelenburg gait is classical, that when we want to walk, we want to, I'm sure everybody's expert in hip because Pachore sir is always there as an hip expert, so I don't need to explain the Trendelenburg gait. But still, I mean, you would want to lift your pelvis on the opposite side to have a ground clearance. So if your abductor muscles are weak, you will have a lurching kind of a gait. We call it a Trendelenburg gait, which is a lurching gait in more common sense, that your pelvis will fall on one side and patient will have a peculiar gait, what we call a Trendelenburg gait. The height stamping gait generally happens in a foot drop kind of a thing, or your patient has some other neuromuscular problem where the total sensation is gone. So if the sole sensation, if your patient is not having, patient cannot feel where is the ground. So patient doesn't have basically a three-dimensional, or patient doesn't have a spatial orientation where the foot is in a space. So if patient's eyes are closed, patient will sway. Not only sway, patient will have a high stamping gait, just because patient is not sure where is the ground and where the ground stops. So wide base gait generally comes when patient is having imbalance. So a myelopathy or even a lumbar canal stenosis, sometimes patient can have a wide base gait. Swelling could be a symptom for the patient. Deformity could be a symptom of a patient. Constitutional symptoms will have would suggest infection. Classical would be, I have always seen that first symptom of any infection, whether it is a post-operative infection, whether it is a spinal infection, whether it is knee infection, is loss of appetite. So if your patients, even in a post-operative period, if patient said, sir, bhook nahi lagti, not immediately, but after 6, 7, 8 days time, bhook nahi lagti, patient is having some pain, always keep your ears open for infection, because that is the first symptom. Just like in COVID, we have a smell loss, which is one of the early symptoms. Similarly, apathy for food is the first sign of any infection in human body. So evening right temperature, we all know that can come in a metastasis or a cancer or a tuberculosis infection. Muscle weakness, patient can come with the symptoms of muscle weakness. Patient is having some difficulty with muscle. Sleep disturbances. Now, most of the time, what I have seen a female patient, sleep disturbance and back pain is a classical triad of psychological origin of pain, right? So if you're having a female patient with elderly age group and patient is having a sleep disturbance, then generally we consider this as a psychological kind of a back pain. Bowel bladder is very important. Patient may come with bowel bladder symptoms. Patient may have a paralysis of bowel bladder. So never your examination or symptomatology ends without examining or talking about bowel bladder. Now there are 3 types of bladder symptoms. Patient can have a reflexic bladder or a spastic bladder, areflexis or an autonomous bladder, and a sensory kind of a bladder. Generally, we don't see sensory kind of a bladder. Autonomous and a sensory is more or less combined. So you can divide 2 up. The UMN or a reflexic kind of a bladder is above L1. Below L1 injury is mainly areflexis or autonomous bladder function. What happens in upper motor neuron kind of a bladder, where because of spasticity, the capacity of bladder is reduced. Detrusor will not relax with filling in the volume, and that will lead to frequency of micturition, urgency of micturition, overflow incontinence. This patient is having overflow incontinence. Bladder is no longer able to hold the urine, and that's why it will leak out. So that is what we call it as overflow incontinence. So voiding generally is unpredictable, can come suddenly. You just can cough, and capacity is so slow that patient will have a urination, and it will lead to an incomplete evacuation also. In kind of an autonomous or areflexic bladder, which is mainly a lower motor neuron manifestation, is generally that paralytic bladder. The capacity is more, so patient will have a most post-void volume. Patient will have retention. Patient will have dribbling incontinence. So because it is filling up, it will go on filling. Patient will not realize that bladder is getting filled up and will start getting dribbled out. So this is 2 main type of bladder we have to remember when we are talking about spine. One is a spastic bladder, or another one is areflexis or autonomous bladder function. Bowel, very rarely I have seen that patient comes until unless patient is having a full-blown Kodaikwana syndrome. Patient generally don't complain bowel symptoms. Patient's only symptoms would be constipation. Patient will say that I have not passed motion since so long. Because of some sympathetic disturbance or whatever, patient's bowel movement also get disturbed, and generally patient's symptom would be only bladder paralysis, retention. પેશાબ ઉતરતો નથી, પેશાબ થઈ જાય છે, પેશાબમાં ખબર પડતી નથી. These are the first symptoms, and then when last they say કે stool pass થઈ જાય ખબર નથી પડતી. But first symptoms, when patient comes to an acute phase, it always constipation, never the diarrhea. Then later on it will lead to diarrhea. So stool incontinence symptoms comes very later, that we have to identify by our own examination whether patient is having a stool incontinence or paralysis. Then we come to past history. Generally acute back pain will corroborate well with weightlifting, prolonged rough traveling, unaccustomed physical activity. I had a patient not very recently but long back. Patient had suddenly walked 7-8 kilometers and patient come with acute psoas spasm. Patient was not able to walk. Patient had a stooped gait, breathing pain, and patient was examined with every possible aspect, and there was nothing on MRI, nothing on X-ray, no clinical signs, and patient was not able to walk. And only probably we detailed about that patient suddenly had walked 7 to 8 kilometers on one day, and then after reflexly patient went into a spasm kind of a thing. We just put patient on muscle relaxant and psoas stretching exercise, and patient improved significantly. So any unaccustomed physical activity is a very important physical exam. The history taking you need to stress upon. Recent surgeries like abdominal surgeries. I'll be more worried about abdominal surgeries, a patient presenting with back pain. Why? Any idea why?
No, sir. No.
Okay, so we have seen many cases who had undergone some kind of an abdominal surgery. If you think about anatomy, the disc is right there. So in kind of abdominal surgeries, chances of post-operative spondylodiscitis is very common. That is one reason I would want to stress upon abdominal surgery. Second, if it has been a massive abdominal surgery, the core muscle is always weak, right? Because it is generally muscle cutting approach. So core muscle weakness will lead to again muscle fatigue kind of a back pain. So these two things you always have to remember. This patient may have a spondylodiscitis, and of course, there will be other symptoms as well. But patient coming with chronic back pain with maybe a major abdominal surgery, my first focus would be to strengthen abdominal muscles rather than anything else. If you strengthen core muscle, your patient will improve significantly. Spine surgery, always we are afraid about revision surgery. Hip knee surgery, those who shall be know that how important hip and knee surgery are in spine examination. Cardiac intervention, I would want to check, because if I'm planning any kind of intervention procedure, the patient might be on blood thinners. Acute onset of, we have seen patient coming with acute onset of paralysis with recent history of some kind of cardiac intervention. What would you suspect in this patient? A patient has undergone PTCA just 3 weeks back. Patient comes with acute paralysis in an ER. What first thing should come to your mind?
Cauda equina, sir.
No, this is cauda equina. Acute thing should come in is kind of probably some kind of hematoma, because bleeding diathesis may come in. So this is very important to ask about cardiac intervention. If patient is on blood thinners, specifically warfarin, patient may have multiple I have operated 3 such cases with patient came with acute hematoma in ER, paraplegia, and patient had only recent history of PTCA or some kind of blood thinners patient was taking. So this is very important to check that what patient's medical histories are. Medical history, of course, drug allergy is always important, because you would want to give some drug to your patients. Always no drug allergy. Diabetes, in particularly spine, important is polyneuropathy. I would want to rule out polyneuropathy in each and every of my patients. How do you rule out polyneuropathy from symptoms? So generally in polyneuropathy, the symptoms of numbness will be very patchy. It is not a dermatomal numbness. It's a patchy. It's a stock and glows. The periphery, the patient will complain toe numbness, sole numbness, hand numbness. So these are glow and stocking kind of a numbness patient will have. I have seen at least 7 patients so far. That patient with uncontrolled diabetes comes with sudden onset of significant disability. That patient is wheelchair bound suddenly. Patient has no neurological issue, but patient suddenly is wheelchair bound, and only symptoms is patient is having lumbar canal stenosis. So diabetes has a direct, it's like a silent attack. Sometimes diabetes, because of diabetes, the nerve function is not proper and pain may not be a presenting symptoms, and patient keeps on pulling on, and suddenly patient comes with significant disability. So to know diabetes and level of control of diabetes is very important in managing your patient with any kind of nerve injury. Hypertension per se is an probably anesthetic point of view, or a stress headache, or stress related thing. You can identify that patient is a type A personality or not. So that hypertension is one very timid thing. IHD, I already said that blood thinners are very important. Past history of cancer or tuberculosis for relapses, because of whether the cancer is metastasized, whether TB has relapsed. Now TB, especially in childhood, is a very important history to ask for, because this is one of our patients comes with significant kyphosis, neglected tuberculosis. So always past history of tuberculosis leads to so many of diagnoses in our patient. Another very important aspect we all clinicians miss in spine examination is an OBGY examination. If it is a female patient, we always have to want to know LMP. Why I would want to know last menstrual period of my patient? Why?
If a patient has reached menopause or not, we need to
know. No, that menopause is still, I would want to ask last
LMP,
because I would want to
pain.
No, I would want to send patient for some kind of investigation, X-ray. So if patient has missed his cycle, I would want first patient to go and test the pregnancy, if it is in a childbearing age, or they are planning child or not. So very important to note down. See, this is very important medico-legally also, that if you don't note this down, LMP, to your young female patient, and if patient is conceiving later on and comes with some kind of childbirth deformity, they can sue you. Like, you got that X-ray done while patient was in a gestation period, and that's why my child is congenitally wrong. So always note down LMP before you order any kind of X-ray to your patient. Pregnancy history is very important. If patient is multi-gravida, patient generally has a very, I would say, in my, I can't put a theory on that, but multi-gravida female are generally neglected female. So they have a lot of psychological issues, they have a lot of mental issues, a lot of personal issues, and patient will have a lot of muscular issue as well. So this multi-gravida patient coming with a lot of back pain, my diagnosis would be it's a functional pain. Patient is having fibromyalgic pain, so I would want to treat this patient first on psychological point of view, and then if I fail, then I would, of course, if there are no red flag signs, but I would want to treat this patient mainly on lines of functional aspect of pain. A recent history of pregnancy. Now in Indian setup, this is very important, because our pregnant ladies postpartum, they generally don't exercise. Now our saying is that you remain in bed, you don't do this, you don't do that, and patients start losing muscle tone. So when they actually start walking, they start having back pain. Another important thing of recent history is generally these mothers are lactating mothers. So you would want to restrict some of the medicine which you would want to give to your mother. Third important thing is, their sleep cycle is totally haywire. They are not sleeping because the child will not allow them to sleep. And any lack of sleep will lead to back pains, body pains, fibromyalgic pain. So if patient has a history of fibromyalgia, it will 100% will get aggravated post-pregnancy. So you must know that, what is the pregnancy status of your patient. Pelvic inflammatory disease, everybody knows, has this very strong correlation with back pain. Copperty, this is another thing which I have found in my practice, that, many our female, they use copperty and they forget to get it removed or changed in right time. So this copperty can also lead to PID. So I have seen patients who has an X-ray copperty. First thing what I would ask is whether you have a leukorrhea or not. And if they have a leukorrhea, before I start my treatment, I'll send this patient for a gynecological examination. And if it turns out to be a PID, then I will hand over the patient to my gynecologist rather than treating me. So these are the signs which actually leads to some kind of a diagnosis in your patient, that how you think about a patient. Menopause, as everybody says, that menopause has multiple issues. We see day in and day out that a female of around 40-45, they come with some kind of back pain. You treat the patient, they are not getting treated, they don't improve in thing, and what they are having is probably many patients are having perimenopausal symptoms, and this perimenopausal symptoms are so much underrated in our society that neither female want to accept nor doctors accept. We generally just keep on giving them painkillers. The idea is these patients require a very aggressive kind of a psychological as well as physical rehabilitation. So identifying a patient with perimenopausal symptoms is very important in your clinical clinical practice. I always ask your patient around 40-45, what is your last period? Sir, abhi to period to આવે છે અત્યારે, એટલે હું આપણે પૂછીએ એમને કે બીજા કોઈ symptoms છે? What are the other symptoms of menopausal? Hot flushes, mood swings, aggressive nature, sleep disturbance. So these are 4-5 symptoms you should aggressively ask to this patient to identify whether they are into perimenopausal symptoms or not. They will have non-dermatomal pain. They will have, on multiple, they will come with thick piles. Nobody is able to treat them. You give them tryptophan, your patient within 15 days time, patient will come happy. Right? So this is very important to identify whether patient is in a perimenopausal symptoms or not. Patient will say hysterectomy. When you ask patient period, sir, hysterectomy karavi દીધી. Now, any bearing on this hysterectomy and menopause? Any bearing, yes or no? Yes. So it is very important to ask. Yes, always important to ask, because in some villages, they also remove ovaries too. So always very important to ask your patient whether અંડાશય કરવામાં કર્યું છે કે નહીં, કેમ કે લોકોને ખબર હોય. જો એ કરેલું હોય, then patient might have some kind of osteoporotic problem, and that can lead to multiple issues to your patient. Now let us come to inspection. Always adequately strip your patient. Generally in our private practice, we don't ask our patient to bare naked there into an underwear kind of a setting, but ideally in exam point of view, always need to adequately strip your patient. Always first observe general condition of the patient, whether patient looking well or patient is looking sick, because generally the face gives away how much pain patient is having, whether patient. So that is why we have devised a VAS, right? The visual analog scale, that we look at the patient face and we can identify whether patient is in misery or patient is comfortable. Chit chatting, happy go lucky patient generally doesn't have a serious problem. So when you look at the patient, you know that whether this patient is having a serious problem or patient is not having a serious problem, just by looking at his face. Anxious face is always evident. Patient is so anxious, so ડરેલું લાગે, તમને મોઢામાંથી ખબર પડી જાય કે આ patient સખત ડરેલું છે. So always give notice to all this particular thing. Physiological age of a patient is another very important thing. I have seen ladies coming at 84 years, but when you look at them, they are just 64. They look like 64. It is chronological age is always 84, but the physiological age patient looks like 64. That changes your plan of action, because ultimately we are disability doctors in spine. So disability, a patient who is physiologically 64 would be different from a patient who is physiologically 84. The demand of life would be different. So it is very important to notice in your mind that what could be the demands of this patient, right? So always inspect from front, back and side to your patient to notice curvature of spine, how they look like. So we always start the moment patient enters, whether patient walking comfortably, whether patient requires support. Sometimes patient comes with 2 patient support, whether patient is a wheelchair bound, because this actually gives different strata of disability to your patient. Posture and shoulder asymmetry can give away scoliosis, can give away spinal deformities. Patients with spinal instability, specifically coming in kind of a compression fracture, post osteoporotic compression fracture, infection, trauma, patient will have very much difficulty to sit to stand. Patient will stand like this, they will put entire weight on their hand and they will try to stand up. Very difficult for a patient to go into the bed or coming out of the bed. So when you ask your patient to sit, lie down, they will be very much uncomfortable while changing this position. Gait, we have already discussed, so I will not go into detail about gait, but you can visualize your patient, how patient is walking, and can make up a first plan about your diagnosis. Always ask patient to locate the pain with their finger, because you would first want to know that where exactly is the pain, what area you want to examine. So always ask patient. So these are the various areas of back pain. Most commonly patient would say that near PSIS, the posterior superior iliac spine, comes with 4-5-IS1 facet joint, sometimes disc injury, sometimes SI joint pain also comes around PSIS. So the location of pain will give away the kind of diagnosis you are looking for. Midline or paraspinal pain generally is coming out from a lumbar motion segment, not a particular thing, but entire motion segment. You ask your patient how the pain is radiating, whether it is a dermatomal or non-dermatomal. Patient will pinpoint a piriformis area or a buttock pain. So buttock pain, we have already seen that comes mainly in 3 kind of a thing. Radiating pain, it could be a piriformis syndrome, or it could be from hip pain also. A patient who is not able to localize pain properly is generally not having a mechanical or structural cause of back pain. They are mainly a functional cause of back pain. Always, as I said, observe patient, how patient is going into bed and coming in out of the bed. If it is very difficult, there is something grossly wrong in your spine. So this is one patient where I would want to go for MRI before I go for X-ray, because a patient who is coming out finding very difficult to go into bed and coming out definitely having some structural pathology in spine. Posture, when you inspect, first thing is gibbus. We call this as a gib, which is a localized swelling on the spine. We gibbus. If it is a generalized kind of a curvature, we call it as a kyphosis. So this is, can anybody say that, what we call this kyphosis in the second image? So this is Schurman's kyphosis. Okay. Right. So when you observe your patient will have a kind of a scoliosis and a rib hump. So always try to identify by forward bending to your patient. And this is a typical posture for patient with ankylosing spondylitis. Patient will be slightly stooped. Patient will look so stiff. Patient will, patient will look like this. It's not able to move. This is an advanced ankylosing spondylitis, but this is a classical posture of your patient with ankylosing spondylitis. You can ask your patient to stand against a wall, keeping occiput, shoulder, buttock, and heels touching the wall. And if it is able to do so, generally patient is in a normal alignment of the spine. If it is not able to do so, it is a positive test and it's positive in ankylosing spondylitis kind of a thing. There will be other aspect also to that, but I probably, this is not subject of this talk, but I'll just cover it up in the next slide. Patient will have a compensatory mechanism for spinal imbalance. When degeneration advances, the spine loses its curvature, starts getting kyphotic, and patient will have gradually hip flexion, hip extension, knee flexion, and ankle extension. So these are the compensatory mechanisms. So if by which the spine will try to keep the head center over the pelvis, right? Because you bend the knee, you extend the hip, you bend the knee and just extend the ankle, your head will fall back and come on a pelvis. And if you try to straighten this, your patient will fall forward, right? So these are the compensatory mechanism which you can observe by looking from the sideways of the spine. I think this is beyond your level, but at DNB level, but you always need to keep in mind. This is a very important thing. A child coming with this kind of a furrow, this kind of a back, a flat back or a hyperlordotic back, you have to suspect patient is having a high-grade spondylolisthesis or even a spondyloptosis. Patient will have extreme lumbar curvature with straight pelvis. Sudden step will come, and these are the patients which are having a spondylolysis and a lytic listhesis or optosis also. So this is how it happens. The lumbar spine goes in lordoflexion while pelvis comes in extension. How do we differentiate between deformity due to pelvic obliquity and spine structural deformity? By making patients sit on a stool. And if it is get obliterated, generally it is a pelvic obliquity and spine will not get obliterated by that. So this is one thing which you can always narrate. Then inspection of skin, always look for surgical scars, sinuses, unusual skin creases, which is corroborating with some kind of a syndromes in your patient, specifically in a pediatric patient. Pigmentation, capillate spots are the pathognomonic for neurofibromatosis. You can even identify multiple neurofibroma in your patient just by looking at. Hairy tuft will be present in spinal dysraphisms, spina bifida, diastropata myelitis, etc. If patient is having some other anomalies like CTV, Down's face, patient can be a syndromic neuromuscular child also. So always go for lookout of all these structures. Now, can anybody say what is this? This is a blue kind of a spots.
Yes, sir.
So this is called Mongolian blue spot. Mongolian blue spot is a normal variation in Asiatic population. Even my daughter had this spot. You can very easily identify a muscle wasting in your patient. If patient is having bilateral uniform muscle wasting, generally I would attribute it to a lack of nutrition rather than a neurological disorder first. So always look out for isolated muscle wasting. Spasm, you can very easily make out your patient will have a furrow or a tight cord like muscle. You can very easily, if you look at the patient's back, of course patient has to be very fatty patient, you can't make out by inspection whether the muscle is spasm or not. PVD, always pathognomic, loss of hair, shiny skin, edematous skin, pigmentation will be there, sometimes may have a venous ulcer as well. So always be lookout for all these signs. I don't need to say much about this thing, that you always have to differentiate hip and knee pathology in your spine. So first thing, you can always look at a knee and tibia vara, tibia valga, FFD of knee. So FFD of knee from FFD of compensatory mechanism of spine, the only way you can make out is FFD from knee will have a fixed FFD, while FFD from compensatory mechanism of spine, you can still straighten the knee. So knee movement will be normal in compensatory FFD coming out of spine, while in OA FFD you cannot abolish the FFD here. So it's a rigid FFD in OA, while in a flexible FFD in compensatory mechanism for spine. So these are main common inspection finding. Generally, alignment disorder is leading to some kind of deformity in spine. It could be scoliosis, it could be kyphosis, it could be lumbar degenerative deformity. Skin, generally we look out for scar, hairy patches, scapular spots, neurofibroma. Muscle, we look out for wasting, asymmetry. Feet, we look out for congenital anomaly. So this is done all in all a brief about what we have to look for inspection. Now let's come for palpation. So we always start with, as I'm sure everybody would know, that we confirmed our inspectory finding by palpation. Whether I don't know whether BMI comes into palpation or in fact inspection or medical comorbidities, but BMI is very important in spine. Higher the BMI, higher chances of back pain, higher chances of residual complication post-operatively, higher chances of failure of conservative management, higher chance of muscle weakness in this patient. So BMI, higher BMI patient, always take it as a pinch of salt. Nutritional status, so always try to look for, I don't measure per se that what is the girth of mid-thigh circumference or mid-calf circumference or arm circumference, but always look for nutritional status, because depleted patient will have a muscle weakness and may not a good candidate even when you are planning for surgery. So always be aware about nutritional status of your patient. By blood investigation, you can check on albumin level. So now in spine fraternity, if your patient's albumin level, if patient is having hypoalbuminemia, we generally don't post our patient for any major spine surgeries. I'm sure it will be same for knee or hip surgeries, but we don't post our patient. We ask them to come after maybe 15 days, 1 month after improving with good nutrition. Mark my word, IV albumin has no role to play, right? So if your patient is nutritionally deficient, hypoalbuminic, and then always ask your patient to get food first and then come for surgery or any treatment. Distal pulsation. So I always start my examination by first ruling out what I can miss. So I never start my spine examination palpation by spine test. I always start with peripheral test: distal pulsation, hip knee movement, and extremity temperature, because these are the three commonest things what we tend to miss in our patient. We are so much engrossed in finding spine pathology that we miss on this three things. So I always start my examination with distal pulsation, hip knee movement, and then extremity temperature. We always should know the surface marking about our spine, so that we can identify what level is there. I actually had kept to ask you, but I think we are already running short of a lot of time, so I'll just quickly go through. This is probably surface anatomy: vertebral prominence C7 spine, spine of scapula T3, inferior angle of scapula is generally T7, iliac crest around 3-4 disc space, PSIS is around S1-2 joint. The interiorly you can go for C2 is the angle of the mandible. Hyoid bone is at C3. Thyroid cartilage at 4-5. Cricoid at C6. And generally the manubrium sterni is generally at C7 T1 angle in a long neck patient. So always keep your surface marking ready when you are planning surgery. Sometimes this the shoulder imbalance, if somebody asks you to how do you measure or palpate the shoulder imbalance, so this is the method by which you can palpate. Draw a line touching the spine of scapula bilaterally, and the line touching the iliac crest, the most superior aspect of iliac crest, and if they are not parallel, your spine patient is having some kind of shoulder imbalance, list, curvature or something. So this is one way you can palpate this deformity. Other things, sometimes they may ask about how to measure the list, how much amount of list your patient is having. So you can measure by the next. This is the slide which will help you to measure. So this is the C7 plumb line. So this is the straight line from C7 spinous process, and this is the straight line from C7 spinous process, and this is the line bisecting the sacrum. So the gluteal cleft, right? This is a gluteal cleft. We call it as CSLV, central sacral vertical line, and this is a C7 plumb line. So distance between the two is measurement of your list. So you have to mention right 5 centimeter list, right? If somebody asks you in examination, this is the way you measure the list. Then movement of lumbar spine, we call it a Schober's test. I'm sure everybody would be knowing that what is Schober's test. So you measure 5 centimeter below the PSI as a dimple of Venus and 10 centimeter above the same line. So this is total 15 centimeter. Ask your patient to bend forward and try to touch the toes and measure the distance again. The difference of difference is the movement of spine, which is mostly around 2 centimeter to 5 centimeter in a normal patient. You can keep 2 fingers on spinous process and just check whether the spinous process are getting apart while bending or not. If it is not happening, then your patient may have some kind of an inflammatory arthropathy. Patient may have ankylosing spondylitis. We can measure chest expansion. I'm sure everybody knows this, how to measure chest expansion. A classical sign of ankylosing spondylitis. Any patient with ankylosing spondylitis, always keep measuring chest expansion, because reducing chest expansion is a sign of progression of ankylosing spondylitis. So these are different movements of the spine, and this is normal range of movement of spine. I don't think that you need to go in detail with this normal range of movement of spine. Always remember, flexion is more than extension in spine. Flexion is always more than extension in spine. So cervical and lumbar spine more flexible than thoracic spine. Palpate paraspinal muscle for spasm. Tenderness, muscle will be tender. Always look out for superficial and deep tenderness. Superficial tenderness generally indicates muscle pain. Deep tenderness is generally bony tenderness. If your patient has a diffuse bony tenderness, wherever you touch on bone, patient is pain. What does it suggest? So this is one sign of your patient might be having a weak bone, right? Osteoporosis or a vitamin D3 deficiency, because osteoporosis leads to bony inflammation because the turnover is very high. So bones are tender in osteoporosis. So subclinical osteoporosis you can always find by pressing your. This is not given in the book, but every clinician believes that so don't try to mention this in your exam. But for your practical purpose, always remember that when you try to touch your entire body bones are tender, then it is first sign for osteoporosis. So always go for DEXA scan, and 70% of your patient will have osteoporosis in your DEXA scan with this. Now let us come to spine specific examination, a Lessig test or a straight leg raising test. What is the commonest mistake people do while doing this?
They will active SLR.
The most common mistake is, sir, first of all, it's a passive straight leg raising test.
Correct.
And while doing that, the students are not looking towards patient's face. We need to see towards patient's face for wincing.
Correct.
And the other end should be on lower end of thigh to keep leg in full extension.
So you have to stabilize the knee. I think the commonest mistake people make it, they don't stabilize the knee properly. Under exam pressure, they know, but under exam pressure, most of the time what we miss is to stabilize the knee. So always your other hand should be on knee. Your knee ankle should be at 90 degree. If your ankle is plantar flex, then also you can have a pseudo negative, a false negative SLR test. So your plantar should be, the foot should be plantigrade, right? This is another point you always have to keep in mind. So hold the heel of your patient so that when foot doesn't drop, and then do a SLR. So up to 30 degree, just actually the slake on the sciatic nerve is abolished. 30 to 75 is the positive range. If patient is having acute inflamed root, so you can actually identify whether this is a sign of inflammatory neuritis or patient is having compressive thing. So if 0 to 30 degree, if your patient is having positive, then generally it is an inflammatory neuritis. Means it could be an acute disease or your patient is still having nerve inflammation. But sciatic test which comes positive from around 30-40 degree to up to 70 degree, it is a pressure sign, right? So it could be a nerve irritation. If it is a nerve irritation,
Sir, we are not able to hear.
Sorry?
Sir, you are not audible.
Okay, can you hear me now?
Yes, sir.
Okay.
Yes.
So SLR can differentiate. One is inflammatory neuritis, and SLR can differentiate between a compressive neuritis, compressive neuritic pain, right? So first 0 to 35 degree is only it just takes away the slack nerve, so it doesn't stretch now up to 30 degree, right? When you do an SLR up to 30 degree, now doesn't get stretched. So if your patient is having pain in first 30 degree, That means even slightest mobility of nerve is giving pain. So either it is a massive compression or it is an acute inflammation of stretch test positive. For upper lumbar disc herniation, we always go for a FNST, femoral nerve stretch. We try to stretch the femoral nerve by asking your patient to lie prone. Now here also, I think, you always have to bear in mind that, your patient should have a stable pelvis. Patient is not trying to support your body with hand. So hand by side of the patient or just like this, because if patient starts supporting the thigh or something by keeping the patient, your patient can have a negative test. So always pelvis should be free and stable, and then try to do this FNST by holding at ankle, supporting knee, and try to stretch the femoral nerve. So that is positive, generally indicates the upper root involvements. The bowstring sign, which is another very sensitive sign and specific sign also. If your patient is having acute neuritis, your SLR may or may not come positive, but if patient is having this bowstring positive, that is hip flexion, knee flexion, and you try to press around fibular head or in a popliteal fossa, and patient comes with severe pain, that is a positive bowstring sign. This is also a very specific sign for disc herniation. Piriformis stretch test, if patient comes with buttock pain, always try to do a piriformis stretch test by flexing hip, flexing knee, and try to touch the knee on the opposite side of the chest. So if you are testing it for right side piriformis, you are try to touch the knee of the patient on the left side of the chest. So that is how you stretch the piriformis muscle. And if patient is having pain while doing so, your patient may have a piriformis muscle spasm, which could be because of sciatic nerve, which could be because of some other traumatic reason as well. But this is a piriformis stretch test which you need to keep in mind. I only perform one SI joint test all the time. I don't do list of SI joint tests which are given in our book of examination. I only do a Patrick test. If Patrick test is positive, I generally ask my patient to go for SI joint investigation, which is a Faber's test. Faber's is flexion, abduction, external rotation test. So the two important thing is you have to stabilize opposite side pelvis and then try to exert pressure on the ipsilateral knee. If you don't stabilize this, your patient will tilt and your test will come negative. So very important to stabilize and press opposite side of the pelvis so that SI joint is loaded. I will go into much more detail about dermatomal, myotomal when we take up the neurological examination of the spine, because I feel neurological examination of spine is another 1 hour lecture. I can't complete in this lecture. It's impossible unless you understand the neurological basics. So this is generally a dermatomal or a myotomal pattern of your spine. C5 is mainly related with elbow flexion, C6 with wrist extension, C7 with elbow extension, that is tricep muscle, C8 with finger flexion, T1 with finger abduction, L2 with hip flexion, L3 with knee extension, L4 with ankle dorsiflexion, that is tibialis anterior, L5 is EHL, that is great toe dorsiflexion, and S1 is ankle plantar flexion. So these are the group of muscle you should actually try to assess motor wise, power wise, to identify a root. These are very specific muscles for specific routes. So always remember that. Along with, you have to remember the reflexes also, that C5 is mediated, bicep reflex is mediated by C5, supinator by C6, triceps reflex is C7, C8, but mainly C7. Patellar reflex is L3, 4. L5, ankle reflex is generally S1, S2. There is no specific reflex for L5. Generally, the everter reflex they call it, but I don't think that, L5 is very easy to demonstrate. So I think L5 doesn't have a specific reflex, but patellar reflex for L3, 4, ankle reflex S1 to dermatome, C5 biceps is C5, supinator is C6, that is brachioradialis, triceps is C7, right? Abdominals, we all know that abdominals can, but L1, L2, L3 generally is not elicited by any of the reflexes. It always overlap with abdominal, but you can't elicit L1, L2, L3, L4 patellar, L3, L4 patellar, S2 ankle. No specific reflex for L5 dermatome. Sensory, we always, for lower limb, which check, I always start with first web space in the toe, which is classical for L5. L5, you can even check sensations at the lateral malleoli. Medial malleoli is L4, or medial side of entire tibia is L4. Just above patella is L3. mid thigh is L2, and around groin region is L1. So you can, these are the specific dermatomal for sensation. S1 is on the posterior or a calf is S1, and S2 is mid thigh, posterior mid thigh. S3, 4 is around the NS. So always try to always measure this sensation in a dermatomal pattern. Start from L5 on the front of the leg, and from the back of the leg from S1, S2, S2, 3, 4. And anal wink is classical reflex for your sacral roots. So if sacral roots are involved in damage, you will not have anal wink reflex. So this is specific reflex for lower sacral roots. So anal wink you have to elicit always in span examination, because this is the only thing which can detect whether your patient is in a spinal shock or patient has a root escape. So major symptom wise, this is chart shows all the symptoms that if your patient is having L1 root involvement, patient will have inguinal region pain, patient will have sensory loss in inguinal region, generally will not have motor abnormality, because L1 is mainly iliopsoas. Iliopsoas is supplied by so many other roots that patient isolated L1 patient will not have any motor problem. L2 is again groin and anterior thigh, anterolateral thigh. Patient will have some flexure of hip weakness. Okay, because iliacus major comes from L2. So always L2 will have more pronounced deficit in iliopsoas than L1. L3 is quadriceps and medial aspect of the thigh. L4 is medial foreleg, or even L4 goes up to tibia, posterior anteromedial aspect of tibia, and L4 will also have a TA. Sometimes even L4 have a quadricep weakness. So there is always overlap about muscle. You cannot specify pinpoint muscle. That quadricep weakness will always mean that your patient will have L3 weakness. Even in L4 your patient can have a quadricep weakness. We have seen patients coming with L4, 5 foraminal disc. That means patient will have L4 root involvement, patient will have knee pain. I have operated those kind of patient will have knee pain, right? So L5 will have lateral aspect of thigh, lateral aspect of leg, front of foot pain, and patient will have EHL weakness. S1 posterior calf or posterior thigh pain, patient will have a plantar flexion weakness. S24 generally medial of the buttock, in a cheek bone, the buttock cheek will pain, around the nettle cleft pain will be there. S24 pain is very rare until and unless patient is having chordoma or trauma or other things. So we don't see clinically S24 involvement because there is no disc herniation there. So reflexes, I think I will not go in much detail here because I already mentioned much of the thing. Always look out for hyperreflexia and positive Babinski, because that indicates that a patient is having maybe tendon stenosis or something above. So your examination is never done until and unless you have ruled out upper motor neuron problem. So Babinski and hyperreflexia, these two things can differentiate between cervical problem or a thoracic problem or a lower lumbar problem. We'll take this reflexes, how it works and everything in detail in probably next thing. Now it is very important to identify malingering patient, because we many times see malingering patients. So just to complete this examination part, there are main 4 aspects: reverse sciatic stretch sign. So you just plantar flexion, the patient is lying supine on a bed, you plantar flex the foot of your patient and patient will have pain, right? This is reverse to SLR. You are actually relaxing sciatic now by doing a plantar flexion, and if patient still complains of pain, that means patient is feigning the pain. If patient is doing SLR, if patient is having pain, ask your patient to sit and try to do an SLR. Patient might not have pain in that time. So that is a classical sign of another malingering. If you remember McNabb had a beautiful picture. You ask your patient to kneel on the stool and just try to touch the stool, and patient will not have pain. Hoover's test is generally for true leg weakness. Anybody can say what is Hoover's test?
Yes, sir. Patient is lying supine and our both hands are below patient's heel. So if genuinely patient is trying to do left SLR, then his right heel will exert some pressure in our right hand.
So if it is a genuine
weakness, doesn't exert pressure, then patient is malingering.
Yes, very good. So if patient is having genuine weakness, patient will try to push the normal leg and then try to lift the affected leg. But if there is no pressure, that means patient is feigning a weakness. And what is Weddell sign?
Sir, Weddell described 5 signs of malingering. The first one is non-anatomical distribution. Second one is exaggerated pain with non-anatomical stimulus. Third one is distraction. Distraction sign, and I forget other two signs. Sir.
So basically what I remember from my PG days is anything which is non-dermatomal, non-specific, diffuse pain, hyper pain out of proportion of the stimuli is generally considered a Weddell's positive, and that is patient is malingering for the patient. So always, try to rule out all these things when you suspect malingering for the patient. Now there are few tips which everybody need to understand and remember while examining a patient, that how to differentiate a patient's pain from ONE from the spine pain. Both can have anterior thigh pain, both will have walking difficulties, both will have more or less sometimes similar pain. Then how would you differentiate between the two? Clinically, your patient is having lumbar canal stenosis. Supposedly, diagnostic MRI is there, patient shows a lumbar canal stenosis. X-ray is there, patient is having severe ONE. How do you differentiate which symptoms are predominant to the patient?
No idea, sir. No.
So for knee, if your patient is having radiating pain, dermatomal radiating pain, generally the situation is very clear that it is a spine pain. The confusion comes in claudication. Whether patient is not able to walk because of knee or not, patient is not able to walk because of spine. So always try to, the first step of the patient in knee arthritis is always painful, right? Spine, after some distance, patient's disability starts. One. Second, you ask your patient to get up from the chair. And if patient is finding very difficult, patient, actually gets up on his back. Patient will first stoop, then will gradually, first straighten the back, and then hand will try to straighten the knee. So that is a patient is having more knee disability than the spine disability. And patient will say that while getting up from sitting position, he or she is having knee pain, right? So these are three things probably helps us to differentiate between claudication coming out of knee or a spine, right? Hip pathology, it's very clear that patient, you can just check the rotation of the hip and you can identify whether patient is having hip pathology or not. Very important sign, very quick test is active SLR. The importance of active SLR, because if your patient is able to do active SLR, hold the leg at 30 degree, then generally your quadricep axis is intact, your hip is intact, your iliopsoas mechanism is also intact. So more or less the single most test which says that neurologically patient is having good power is ask your patient to do active SLR and hold it at 30 degree for 30 seconds. If patient is able to do so, I can more or less say that patient's power is normal. If I want to quickly examine the power of the patient in single go, right? So hip, if it is a patient is having subcapital fracture, I'm sure you will know that patient will not be able to do an active SLR. Though patient is able to walk, patient will impacted fracture, patient will not be able to easily do active SLR or hold it for 30 seconds, right? Always remember red flag signs in spine of Koda equina syndrome, bowel bladder, acute severe pain. Alpha S, very interesting type is alpha S1 central large disc herniation. Patient will not have any kind of radiating pain. Patient will have severe back pain, so much so that patient walk with flex attitude. Patient is not able to straighten. And patient will have urinary retention, patient will have, so this thing which you always have to identify, because this is impending coda, right? If you neglect this part, your patient will have a full-blown coda and you will not be able to do anything. So severe acute lower back pain, where patient is in a flex position, patient is breathing in pain, patient has a urinary retention. First thing you should go for is MRI and try to find, and most likely patient will have a large central alpha S1 disc herniation. Diagnostic of radiation, we all know that dermatomal pattern has to be there. Diagnostic of NIC, we already have discussed the differentiating features of vascular and neurogenic claudication. And diagnostic of spine instability, I have already discussed that positional change will have more pain. Once position is obtained, like in a compression fracture, we many times see that patient has only difficulty by turning in bed, getting out of the bed, going into the bed, sit to stand. Once patient is standing, patient is able to walk. Though patient has a compression fracture, because once patient comes in a normal position, the energy expenditure by muscle is minimum. The movement becomes very minimum. So that is, change of position gives pain, that indicates spinal instability. Patient will have a significant muscle spasm. Furrows of spinal paraspinal muscle will be visible. Patient will have a rib cage pain and patient will have a iliac crest pain. Why? Because if you remember, quadratus lumborum has origin from lower ribs and attaches on the iliac crest. So if your patient is having instability, this paraspinal muscle goes in a chronic spasm, and that pulls on periosteum of this bone, and that leads to a rib cage pain the lower rib cage pain as well as the iliac crest pain to your patient, right? So these are sign of spinal instability. Your body is trying to protect the spine while going into spasm. So I guess more or less we will end this here, because neurological examination is beyond the scope to talk for another hour. And we will, next lecture, I think we will try to cover up cervical thoracic examination and neurological examination both. So if anybody has any questions.
Yes, anybody wants to ask any question?
So people can ask question if somebody want to ask. Just unmute the mic and ask. Vasavada sir, your mic is mute. Vasavada sir, your mic is mute. You are trying to ask. Okay.
Yes, sir. You can speak, Vasavada sir. Yes, sir.
Niraj, regarding vascular and the claudication and neurological, the one of the things which is in vascular claudication, the pain or numbness, whatever things start from distal to proximal, and in a neurology it is from proximal to distal. That is one important finding. So that is.
Correct, sir. I have not included that, because in many of the patients, sometimes patient is not able to pinpoint, whether it goes up or it goes down. So I did not, but it's a very valid point. I think, for completion, it must be included.
All the boys have to immediately take the history of smoking.
Correct.
For a vascular claudication, that becomes a very easy exam, that one day you will miss that history of smoking.
Right, sir.
That is another
important. Yes, I think I missed that slide. I have mentioned that smoking is very, very important, because smoking has direct correlation with back pain. Direct correlation with back pain, direct correlation with vascular problem, and direct correlation with post-operative fusion. A smoker has a 30 to 35% chance of pseudoarthrosis in lumbar spine fusion surgeries. So if a patient is smoking, I think better explain the patient higher chances of pseudoarthrosis.
Yeah, that is another. But you have covered quite a lot. Also, I learned a lot of things.
Yes, sir. Lecture was very good, and lecture was in very detail. Yes,
no,
sir.
I think my lecture was not an exam point of view, but it was more on a clinical.
Yes, sir.
How I think about. I think I have lost the touch of giving a lecture for your exam purpose. Only thing as I said in the beginning, that only reply things which you know about. Otherwise examiner will pull you on if you don't speak something and if you don't know about that.
Yes,
so,
sir. Yes.
Always be careful that always speak which is common, which you know about. Don't try to show off that uncommon things very easily. So always give very common reply, so that you can actually go this. Like I'll give you one example, sir. I think my short case was malunited lower end radius, and I think in three cases, all three patients I have said that I will treat conservatively. Patient was non-dominant hand, so I think my plan was not conservative. So my examiner said that are you going to be a orthopedic physician, or you are going to be an orthopedic surgeon? Because it's very easy to talk on conservative treatment rather than operative treatment in exam. So always be what I'm trying to say is conscious about what you are talking, what you are saying in front of examiner. Examiner is looking for something to show off his knowledge. Like
yes,
if you ask me a question, I would want to show my knowledge to you. Right? I'm not interested to learn your knowledge. I'm more interested to show my knowledge.
Yes, sir.
Right. So always remember that.
Yes, sir. Yes, sir. Yes, sir. And Niraj, sir, thank you. Thank you very much. Thank you for your efforts, and thank you for your time, sir. Thank you very much, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.